So, after you all heard about fecal transplants, yeah, they're coming, I guess. C. diff is a big problem. I'm going to go back and talk about another issue related to the liver, which is the interactions of drugs in the liver. And the reason that we're doing this is that the liver is so intimately involved with handling drugs, and there can be many different outcomes as drug meets liver. Drug elimination is the main purpose of having an organ that has a lot of capability in altering xenobiotics. But that can lead to drug-drug interactions, liver diseases, drug metabolites, which can be good or bad depending on the drug. And this is something that confuses a lot of people, so I wanted to give you some concepts to think about. So the liver is a major biotransforming and elimination organ, so that's its role as a barrier and a garbage disposal unit. However, in the process, you can have interactions between different compounds that are all being metabolized. It can increase toxicity or decrease effect of one or more of your drugs. Drugs themselves can cause liver damage. Often that's by a product that's created in the liver. Can we predict that? And then, of course, if you have liver disease and the liver doesn't work, disposal of drugs or alteration of xenobiotics is one of the liver functions, so that will be altered. And so I know that when you had nephrology, you talked about with chronic renal insufficiency, if the kidney can't eliminate various drugs, you may have to alter their dosing. Does that sort of ring a bell? Okay. Well, we deal with the same problem in the liver, except that we can't measure something easy like the creatinine clearance. So first of all, in terms of a barrier function, the gut wall and the liver are barriers to potentially undesirable chemical xenobiotics that are taken in by mouth, either as nice little pills or with whatever your hunter-gatherer relatives ingested, etc. It's not perfect. They're clearly plant toxins that we can't handle. And they can either be in the lining of the mucosa or in the liver as everything comes up, and then we have the bile as a way of returning undesirable products to the gut. And there's multiple steps, and of course, each one's different for every drug, which is why this gets so complicated. So I just want to remind you of a few pharmacokinetic terms. The liver removal of things from blood is termed hepatic clearance. It's actually a complex process due to a number of steps, but you can reduce it to three things. How good is the liver blood flow, which is providing the compound to the liver per minute? What's the liver's intrinsic ability to take it up and or get rid of it? And anything that's bound to albumin is not going to be taken up very rapidly by the liver. The free one is taken up much more quickly. So you get these kinds of equations from the pharmacokineticists. The total ability of the liver to handle or get rid of some agent is equal to blood flow times the fraction of unbound blood times the intrinsic ability of the liver over flow plus the unbound fraction plus the intrinsic clearance. Well, this means if you can get rid of one or two of these denominators, then the equation simplifies. It, of course, depends on whether you know some of these things, and we know them better in theory than we often do in fact. But it means that you can sort of categorize many agents into one of two groups. One is high extraction drugs. These are drugs where the ability of the liver to clear it is so high that the denominator, this number is so high, it's much greater than blood flow. So blood flow kind of drops out, that divides in, and you get blood flow. So the hepatic clearance is determined strictly by liver blood flow. So if you somehow alter liver blood flow or divert it around the liver, remember we're talking about varices, then you will alter the liver's ability to get rid of this drug. Because remember, the liver, because it's in series, has the ability to virtually strip blood of some compounds if it's got a high extraction ability. So in a single pass through the liver, you can eliminate things. Now, there are a number of things that are normally highly extracted in a single pass through the liver. Some of these are drugs. Nitroglycerin and lidocaine are two of them. We do not give these drugs as pills. They don't work as pills. They don't make it through the liver. So you absorb them in the small bowel, they go in the portal vein, they do not come out in the hepatic vein. So these are drugs. There are certain agents that you must give intravenously because either they're not absorbed by the intestine or they're cleared in a single pass through the liver. And that's nitroglycerin and lidocaine. They work great if you give them by another route. Propranolol is highly cleared in a single pass, but about 10% makes it through. So therefore, you can use propranolol orally. But look in your little Hippocrates or whatever you look at for drugs and look at the IV dose versus the oral dose. The oral dose is 10 times higher. Because in order to get it into the systemic circulation, you have to get it past the liver and you lose 9/10 of it. Bile acids are highly extracted. You really do, these are detergents. You don't want them circulating in large concentrations. So in the enterohepatic circulation, they go out of the liver, down the gut, up into the portal blood, into the liver, back around. Very little is in the systemic circulation. So high extraction drugs are things that are rapidly cleared and eliminated either by metabolism to something else or excretion into bile. Sometimes what they're eliminated into goes out in the urine. Oral administration of these kinds of drugs is highly inefficient. On the other hand, the enterohepatic circulation of bile acids is highly efficient. So it depends on what you're trying to do. Low extraction drugs are drugs where the rate limiting step is the ability to pick up or eliminate. So these drugs are only slowly taken out. It takes many passes through the liver to finally get rid of them. And so, yes, the liver can take them up, but it doesn't do so very rapidly. So a lot of it gets through to the systemic circulation. This is what the pharmaceutical companies are looking for when they're developing an oral pill. First, they have to look at the gut. Is it even absorbed? If it's not absorbed and it doesn't, its location of action is not the gut lumen, then you're in trouble. If it's rapidly cleared by the liver, you can be in trouble. So they have to look at those two things early on. Lots of drugs are low extraction fraction, and bilirubin is fairly. These are just some examples that have been used for testing. However, it means these drugs have a high oral bioavailability, so they make great pills. And they're not going to be gotten rid of quickly, so you can have a prolonged mechanism of action, and patients don't have to take them as often, which is always nice. Well, what does the liver do to get rid of drugs? It biotransforms a lot of them after it transports them. So it has to get them in. And the liver does have a lot of versatile transporters for organic and inorganic compounds. Secondly, you need to alter the structures to figure out how to get rid of them. Yeah, sorry.
In terms of the drugs, is there anything about the chemical nature of a compound that you can look at and know if the liver is going to clear it faster or not?
The liver tends to take care of the larger compounds and the more lipophilic ones. Very small molecules that can be filtered in the glomerulus in the kidney that are really water soluble, those tend to go out in the kidney. And of course, some drugs, both happens. But think of the liver as dealing with the larger compounds and or more lipophilic. And so it can get rid of compounds by either excreting them into bile or once they've been modified, for example, either breaking them up into smaller molecules or making them more hydrophilic, they can go back out in blood and then get eliminated by the kidney. Now, these compounds clearly weren't invented originally to deal with drugs. They're in animal species of many different kinds, and therefore they really were engineered to deal with all the xenobiotics, all the wonderful things that plants make. And I just want to show you some examples of how you might think of these biomodification processes. They get classified into two groups, a phase 1 and a phase 2. They're both related to or on the outside or stuck in the endoplasmic reticulum. So that's the part of the cell where a lot of this takes place. Phase 1 are the CYPs, cytochrome P450s. These are more oxidative reactions. Phase 2 are throwing water-soluble groups onto molecules, and those are making them usually more hydrophobic. Those are conjugation reactions. And often materials go through a series of these. So phase 1, the biotransformation, that's direct modification of primary structure. They're usually oxidative. You're often adding reactive hydrophilic groups. This is often a rate-limiting step. The fact that you're adding a lot of, this is a reactive group you're adding, sometimes you can generate toxic metabolites. And this is an area, and I'll show you why, where there's a lot of drug-drug interaction. Drugs can compete for the same CYP. These are also highly variable. There's tremendous genetic polymorphisms, and some of these can be induced and they can be suppressed. So each person has a different pattern of these, and it accounts for a lot of the small individual variation in either response to drugs or in metabolites. So the CYPs, there's an apoprotein, there's a heme ring with an iron in the middle. This is the other reason you need iron, not just for red cells, but for your cytochromes. And that's the active site. Now, these all have names. They're now all called CYPs. They then have a number, a letter, and possibly a second one. There's an enormous number of these. There's no way you can memorize all the names. But you need to recall what these are, because nowadays all drugs that are produced have to have, before they're licensed by the FDA, the companies have to figure out which CYPs handle these, and so that you can look them up for drug-drug interactions. And if you look in Hippocrates under pharmacology, it tells you, are there CYPs that handle these? Which ones? And if you have a patient on 2 drugs that utilize the same CYP, you can have interactions because they'll compete with each other for metabolism. 3A4 is the one that handles more drugs than any other one, but 2D6 and a couple of others are pretty common. And we're going to refer to a few of these when I show you some examples. So this is what happens when you have genetic polymorphisms, i.e. what you're born with, not what you acquired environmentally. This was all worked out years ago for a drug which is no longer used because of the tremendous variability, called dazipramine, but there are other drugs that use this same one. This is 2D6. So it's not one of the bigger ones, but it does metabolize a number of drugs. And it turns out you can divide up the world into fast extensive metabolizers, slow, extensive, and poor. And most of us are in the middle, but there's a fair number of human beings in any population that are at either end. This is showing the log of the blood concentration after you give a single pill. And for the average person, the reason this drug was first developed and sold is that people get a peak, which is not toxic, and there's a fairly slow excretion rate. So you can give it a couple of times a day and get good blood levels. The problem is if you're an extensive fast metabolizer, you get rid of this thing so fast, you may never get an effective dose, and it disappears before your next pill is available. Poor metabolizers, so for them, the drug doesn't work at all. For the poor metabolizers, you can get toxic levels that can remain around for a long time. Now, codeine, which you've probably all heard of as a narcotic, is a prodrug. It's actually morphine. It has to be metabolized by 2D6 before it becomes active. So if you are a rapid metabolizer, you're going to produce morphine very quickly after you take a pill. It gets effective, but it may not last, and then it lasts for a while. If you're a poor metabolizer, this prodrug is never converted to the active metabolite. You don't get any pain relief. So you have to actually ask your patients, if you put them on codeine, did it work for you? If they got sleepy 15 minutes after they took the pill, they may be a rapid metabolizer, and it won't last very long. If it didn't work, They may be it's not that they were giving away the pills or selling them on the market or something. They may be a poor metabolizer. They never made the active metabolite. Okay. So that's what's called converting a prodrug to an active drug. And this is a different drug. It's actually decongestant, but it's the same idea as codeine. The codeine that you take in is not biologically active. It has to go through, in this case, 2D6, but here it's a different one on 3A4. So phase 2, so you can either break down active drugs to something that's inactive and gets disposed of, or you can take a prodrug that's easily absorbed, and now it's activated by going through one of these CYPs. Okay? So phase 2 conjugation, or when you throw on some water-soluble side groups. These can be sugar-based, sulfate, glutathione, which is a peptide, amino acids. This will almost inevitably increase the water solubility. This often follows the CYPs. They will throw on a hydroxyl group, and then the conjugation reaction can use that hydroxyl group to throw on something that makes it more water soluble, although it may be this is the only way a drug is disposed of. So an example is acetaminophen. Here's acetaminophen, active drug. It is glucuronidated by a UDP glucuronal transferase, and that compound is then excreted in urine. And it's inactive. So this is how you get rid of most of the acetaminophen that you take in. Now, conjugation, of course, again, was not invented to deal with acetaminophen. So conjugation happens for endogenous substances. We conjugate bilirubin to glucuronide to get rid of it. We conjugate bile acids to the amino acids, either glycine or taurine, to make them more biologically effective as detergents that work in our system. We don't know much about the genetic polymorphisms here. It probably isn't nearly as polymorphic a system. We don't know that it's inducible. So we think these are a bit more stable from person to person, but I wouldn't bet that that's 100% true. Okay, once drugs have been altered by these phase 1 and phase 2 enzymes, or one of them, they then can be excreted in bile, or they can go out in the blood and go out in the kidneys. And the liver has all these transporters. So I showed you about the bile acid transporter last week that just handles bile acids once they're conjugated. But there's a bilirubin transporter, but it also handles other things. So it actually, there are glutathione conjugates of a number of organic compounds that go out through this transporter. There's some other conjugated organic anions. Then the liver also has a bunch of other transporters. This is the one that, when it's upregulated, causes cancer cells to be resistant to chemotherapy, because it handles a bunch of drugs, many of which are chemotherapeutic drugs, or some of our big immunosuppressive drugs like cyclosporin. It's MDR, or P-glycoprotein, multidrug resistance protein. That's been purified and understood. So a lot of these things that are big and bulky will go out in bile. And we've talked about that the liver uses these mechanisms for both endogenous and xenobiotics, and they're often coordinately regulated by orphan nuclear receptors, another whole area of very complex biochemistry that we're not going to go into. Now, the gut, turns out, does some of this also. The liver is such a workhorse in this that that's where a lot of the preliminary work was done for many years. But once the molecular biology tools became available to actually look for these compounds, you can find them in the gut. Now, the gut's capacity is much less than that of the liver, but it's the first barrier. So it also has the CYPs, and it also has, for example, this MDR, multidrug resistance, ATP-dependent pump, so that it can contribute to excluding these things from the interior space of the body. Now, When you talk about drug-drug interactions, you're really talking about at some of these transporters, enzymes, etc. If you have two drugs there, they're competing, and one may interfere with the other one. So, for example, drug A can increase the toxicity of drug B if they're competing, and I'll show you an example. You can also get induction of a CYP. That can cause you to eliminate some drugs faster, but if there's a toxic metabolite generated, it can make it more toxic. And this is applicable to environmental and natural products as well as drugs. So the case presentation is a young man who underwent a cardiac transplant. He was begun on an immunosuppressive cyclosporin A. Levels were therapeutic for about 2 days. He did fine. But then he developed renal failure and seizures consistent with cyclosporin toxicity. And at this point, his blood levels were very high. So what's happening? Then he had another problem. The dose was reduced. He got back to his therapeutic drug levels. 6 weeks after surgery, his blood levels had fallen too low, and the dose had to be increased. So why is this so difficult to dose? Okay, let's look at the idea of competition. So here are some CYPs lined up on the cytoplasmic face of the endoplasmic reticulum. And there's drug A, which uses this one. There's drug B that uses this one. But if C and D both use this one, 3A4, which, by the way, does handle cyclosporin, they can interfere with each other. So in the absence of competition, your liver, red triangle, has a certain amount of 3A4. You give the patient a certain amount of cyclosporin. You get some that gets through the liver unaltered. You get some that's metabolized. And by altering the dose, you find the right blood level for that patient. Okay. But then you mess it up. Then you give the patient another drug. In this case, ketoconazole, an antifungal. Ketoconazole also utilizes 3A4. So you have the same amount of 3A4. You're giving them the same amount of cyclosporin, but now you have another drug that's competing for metabolism at the active site. You can't metabolize cyclosporin as rapidly. So you have a higher blood level at steady state of cyclosporin and fewer metabolites. This gives you a high blood level. It's toxic. You develop kidney disease, kidney damage, and neurologic symptoms. So when you put in an inhibitor of CYP, you can't break down cyclosporin as rapidly. Blood level goes up. Okay, we also know that this isn't due to genetically low levels. You can eliminate that possibility because his blood levels were low later on and you had stabilized him before. So we think this is a competing drug, and looked at his chart, and he was given ketoconazole. When you look up these drugs, you see both of them are metabolized by CYP3A4. And this is not just a problem with conventional drugs. A problem that the transplant world has had to deal with is patients go out and they buy St. John's wort, which is supposed to be good for a whole lot of things. But it's also metabolized by 3A4. So it can send your cyclosporin or tacrolimus levels way off. And when you're talking about an immunosuppressive drug that has a narrow therapeutic range, this is a really big problem. So there's a bunch of things that we now have listed for patients. If you're on these drugs after a transplant, do not take the following, and St. John's wort got added. Coumadin also goes through that area to a certain extent. And Coumadin and St. John's wort can interact as well. Now, the second problem is that a substrate for a CYP can induce production of more CYP enzyme molecules. Now, this makes sense. It's nice and homeostatic. It messes things up medically. So induction is usually very specific, and this is also through orphan nuclear receptors. So this is an example. This is an animal model. This is a Western blot for CYP3A4 protein. although it could be the RNA. So this is the amount of protein this mouse had to begin with, here and here. And then they were given the drug rifampin. It's an antibiotic used for tuberculosis treatment. It induces the gene for 3A4. Within 1 day, you have a massive increase in the amount of 3A4. At this point, how fast are you going to metabolize cyclosporin? Really fast. The metabolites will all go, you'll have very low blood levels, and you might reject your organ transplant. And you can see by 7 days, it's unbelievably massive. Fortunately, this regulation is reversible. If you take the rifampin away, after a few days, the amount of protein goes down. But it's, again, something you have to think about when you're treating patients on multiple drugs. So in this case, this patient had, because of the seizures that he had, was put on an anti-seizure drug, or it could have been one of these others. That ramps up the CYP very high, and now the cyclosporin comes in, and it's almost all destroyed, and you don't have enough cyclosporin. So in this case, these were anti-seizure drugs. The unaltered, which is the biologically active form, goes down, and now you're at risk for rejection. So the approach to drug-drug interactions, because this is incredibly complicated, is be aware of it, look it up. So I know I get Hippocrates on my little Palm Pilot equivalent, and when I have a patient who's on cyclosporin or tacrolimus or another drug that I know is critical, has a narrow therapeutic window, and I'm going to start them on a new drug, I look up what CYPs that other drug has. And if it's 3A4, I look for an alternative. All of our post-transplant patients are on pravastatin as a statin, our liver transplant. Most of them are middle-aged or older. They may have coronary artery disease. Pravastatin is the one statin that does not go through 3A4. So it's just automatic. They go on pravastatin. I don't care what statin they were on before, they go on pravastatin. All the rest of them go through 3A4. You can monitor the blood levels of your drug. Cyclosporin, we can do levels. Tacrolimus, we can do levels. A lot of things we can. You can monitor biologic action. You can monitor for known toxicity. So the biggest issue here is be aware that this could be a problem and see what kind of monitoring is available for this drug or that drug. Okay, now that gets us to how do drugs affect the liver itself? Can drugs cause liver damage? And the answer is yes, under certain circumstances they can. There's many types of injury. Some are predictable. Most are rare and not easily predictable. These are idiosyncratic, which means we don't yet know why 1 in 100,000 people on a statin drug get severe liver injury. And then there's therapeutic and misadventure that I'll talk about. So drug-induced liver disease can be almost anything. There are textbooks on this. There's big lists. You basically have to look it up. So the first example that was best worked out at the beginning are when the liver produces a toxic metabolite. And that's how isoniazid. Tuberculosis treatment is rife with problems for the liver. That's how they were figured out so early. Isoniazid, there's a toxic metabolite that can be produced. Acetaminophen goes through that pathway. There are autoimmune processes. There's a fluorinated hydrocarbon halothane that is not used much anymore, but it can cause rare, severe hepatotoxicity. And it turns out the halothane forms a hapten, and that leads to an immunologically mediated toxicity to the liver. It can be cholestatic. I talked to you about estrogen, which can have a specific effect on the bilirubin transporter. So let's look at acetaminophen, because you'll all hear about it. And it is, frankly, one of the most common causes of fulminant hepatic failure in England, the United States, overdoses of acetaminophen. So why? It's broad spread. You can buy it in big bottles. It's sold over the counter, but it can cause toxicity. So this is how acetaminophen is handled in the liver. Most of it, under normal circumstances, is glucuronidated or sulfated. That's a stable metabolite. It's excreted, and everything's rosy. There's a little bit that will go down some CYPs. 3A4 is in there, but 2E1 is the biggest one. Those metabolites are toxic, but they can also be glutathione conjugated and gotten rid of. And if the liver doesn't make many of these, it doesn't cause any problems. But in large amounts, these will cause damage, and they can wipe out the liver in about 3 or 4 days after a massive overdose. So we have a problem with a little being good, but a lot may be bad. When you take a massive overdose, and we're talking about 8 to 10 grams in most people, you saturate these glucuronidation pathways. Then more goes down the 2E1, and you now generate a lot of toxic metabolites. So here it's because you've saturated the safe pathway. Now, you can give, there's an antidote. And all of you, when you work on the wards or you're working in the emergency room and somebody comes in and they say, oh, I took a Tylenol overdose, their family comes in clutching the empty bottle of 500 milligram pills that were, 150 of them in there, and say, I think they took all this. If you give some drug called acetylcysteine or Mucomyst, IV or by mouth, that produces a lot of glutathione and allows you to rescue this and limit the toxicity. So you hear possible acetaminophen overdose, you draw blood level, you start the acetylcysteine before you even get the results back. Because you got to get in there early. Once the liver cell's dead, it doesn't work. So what part of the liver will be affected? And is this going to be hepatocellular or cholestatic? It's going to be a hepatocellular or a cholestatic disease. Yeah, because it's the liver cells that themselves are going to get hit first. The toxic metabolites can affect the kidney and other things later on, but it's the liver. And what part of the liver? It's the pericentral area gets hit in milder cases. Now, in a bad enough case, you wipe out everything. But this is where the CYPs tend to be congregated. So this is the area around the central vein where you'll get the most insult or the fastest insult. Now, I wanted to show you just an example of this halothane hepatitis where the immune system gets activated to attack liver cells. And this depends on some cell biology mistakes. No system in your body is perfect. So the CYPs, this is 2E1, are normally tethered to the endoplasmic reticulum. But cell biology being what it is, occasionally some of these make it out to the plasma membrane and sit out there. Now, by themselves, they're there. The immune system has become tolerant to them. And here you're taking the halothane and metabolizing it to another compound. However, this is a very reactive process, and there's a reactive group. And so occasionally you'll get a covalent bond forming between one of the amino acid side chains of the CYP, here in the active site actually, and this forming a neoantigen. Now, as long as this is buried in the middle of the hepatocyte, that is of no clinical consequence. But if some of these get cycled out to the cell membrane, then you've got a hapten, a neoantigen, which can set off immune-mediated damage to the hepatocyte as a whole. And that's the mechanism. Now, drug-induced cholestatic disease certainly exists. We talked about estrogens that have a specific effect on bilirubin and bile acid transport. You can also get all kinds of other things. You can get bile duct injury. You can get fatty liver and a fatty liver hepatitis. You can get injury to the endothelial cells in the small hepatic veins and get something called veno-occlusive disease. And if you happen to work on the bone marrow transplant unit, this is one of the feared complications after a bone marrow transplant from all of the drugs and radiation that were used ahead of time. You can get neoplasms. You can get other types of liver disease. So the message here any liver disease that presents, drug-induced liver disease, is on your differential someplace. Might not be very high, but it's there. Now, therapeutic misadventure is a variant on this theme, where the patient uses a drug at what should be a safe dose, but in the presence of some other environmental or genetic change, toxicity develops. And the biggest example that we see the most clinically is the mixture of acetaminophen and alcohol. So here's a case of a 47-year-old known alcoholic admitted with jaundice and disorientation. A week ago, he developed abdominal pain, which may well have been his alcohol-induced acute pancreatitis, which you will learn about tomorrow. So he stopped drinking. He then wanted to take some pain meds, so he grabbed his handy bottle of acetaminophen, took it for several days. His abdominal pain got better, but then he got jaundiced. He comes into the ER with these laboratory tests. Now, is this alcoholic liver disease? No. Alcohol does not destroy your liver in a short period of time. It destroys your liver in a long period of time, but not in a short period of time. These are some of the highest transaminases you will see. This person has wiped out a lot of hepatocytes and how's their liver function? Prothrombin time normally is 10 to 12 seconds. They've destroyed a lot of liver. So he has severe hepatocellular acute disease with abnormal liver function. So what is this? This is fulminant hepatic failure. And he's disoriented because he also has some encephalopathy. This guy goes straight to the ICU, et cetera, et cetera. So what's happened here? This is the normal pathway I told you about. And here's 2E1, which is going to be a big player. So the mixture is a bad combination. And this is mimicked if you also give isoniazid or phenobarbital and acetaminophen. The reason is all of these induce 2E1. So if you are on tuberculosis therapy or if you're drinking alcohol on a regular basis, your cytochrome CYP2E1 is massively induced. So you've induced this pathway. So now when you take a dose of acetaminophen that otherwise might be fine, you've got a preferential pathway toward the toxic metabolites. So ethanol has induced this. Now it happens that many alcoholics do not exactly have the world's best diet. They're getting a lot of their calorie from alcohol. And so if they're protein deficient, they might not have as much glutathione, and that blocks the safety pathway as well. But one of the big ones is you've induced this one. So with a dose of acetaminophen that would, in you or I, be non-toxic, this person who's an alcoholic may not be able to tolerate. So he's a chronic alcoholic. He was chronically induced as 2E1. He was poorly nourished with low glutathione levels, developed a medical problem for which he got pain. He took the acetaminophen, developed acute massive hepatic necrosis. So when you're thinking about drug-induced liver disease, always consider drugs, herbs, or toxins in your differential diagnosis of all liver diseases. Until you know what it is, stop all drugs the patient's on and look it up. Again, just like for the interactions, we have to have textbooks, computer-based systems to look up for possible interactions or toxicities. But there's no test you can do that say this liver disease is due to a drug, except for the acute problem with acetaminophen, where you can check an acetaminophen level and they characteristically have these astronomically high transaminases. So how do you prevent drug-induced liver disease, interactions or toxicities? Just be aware that there's an issue. Look up the drugs when you're going to start them on a patient. Then, if you're putting somebody on a drug that does have some toxicity, you may monitor for abnormal transaminases. So we do this in patients who start on a statin drug for hypercholesterolemia. They get some liver enzymes checked for the first 5 or 6 months they're on it. That's usually when these rare, severe toxicities show up. Now, we would love to be able to tailor drugs to the patient's known genetic, environmental, and drug profile. We're not there yet. I think they're working on the exaflop computers now for weather predicting, and we might need that in the future, but we don't have enough data. So this is kind of like Vince's talk about the human microbiome. We know it's there. We know it does lots of things. We're appreciating all the many things it does. We can't yet use that in a useful way for an individual. So these backup systems about thinking about the problem and monitoring for liver toxicity are sometimes what we end up having to do. Okay, so what happens when you then have a patient whose liver doesn't work well? Most of them are going to need to be on some kind of drugs. And so what can you do? We have to remember that biotransformation and elimination is a liver function. And therefore, for drugs that are eliminated by the liver, you might get more toxicity at a standard dose. And your codeine may not be as effective. Yeah. There it is. Now, for low clearance drugs, as it turns out, we're really lucky. Unlike the kidney, where it's dependent on perfusion and that goes down as you lose tubules, the liver hepatocytes seem to retain drug metabolizing activities to the very bitter end. So we really don't worry about this until we really have an end-stage cirrhotic. But it is when somebody comes in and their liver function is really bad, then I think you have to consider that most drugs are not going to be eliminated at the same rate, and you'd want to space out the drugs further apart or maybe start with a lower dose and monitor for effectiveness rather than giving them the standard dose. High clearance drugs have a different problem. They're cleared in a single pass through the liver. If portal blood doesn't go through the liver, they're not going to be cleared. Cirrhotics have shunts. The shunts go around the liver. And so for high clearance drugs, you can really alter bioavailability of oral drugs tremendously. Instead of 10% of your oral propranolol getting into the systemic circulation, you may have 80 to 90%. A huge overdose of propranolol can cause what problems? The beta blocker.
Fatigue.
Yeah, you can reduce your heart rate, reduce your blood pressure, develop AV block. Not a great thing. So when you're seeing patients who have cirrhosis, then you need to think am I putting them on a drug that has a high clearance, and this person's going to get a lot more drug in their system faster than someone else would be. Cut down the dose. Now, propranolol, you can measure its side effects. You can look at their pulse. You can look at their blood pressure. So we use propranolol, Dr. Mosley talked to you about that, to reduce pressure in varices to prevent variceal bleeding. I don't start with a standard dose of propranolol. I start with a baby dose of propranolol in these folks. And we have them come in and get their blood pressure and pulse checked. And we gradually increase it until we get the decrease in pulse rate that says you've got enough on board. And so here we're showing that in cirrhosis, instead of all your gut blood going up through the liver, a lot of it is going around. And you don't know how much for any given person is bypassing the liver. So systemic bioavailability can be very high. Now, cirrhosis doesn't do some things. All those weird idiosyncratic sorts of drug toxicities, no higher risk than anybody else. And it doesn't increase the likelihood of autoimmune-mediated drug reactions. So there's some things you don't have to worry about. So how do we approach drug use in patients with liver dysfunction or disease? Doses with a high extraction, such as propranolol, reduce the doses. How can you tell it's high extraction? Other than me telling you that propranolol is high extraction. Look at the IV versus oral dose. If the recommended IV dose is far, far lower than the oral dose, then it's rapid extraction. And for propranolol, that's 10 to 1. If the IV dose and the oral dose are about the same, then it's going to be a well-absorbed drug that is metabolized slowly by the liver. And your little Hippocrates will also tell you, is it hepatic excreted, is it renally excreted? Monitor the biologic effects. Monitor blood levels if you can. Start with a low dose and titrate up. So there are some cirrhotic patients in whom nitroglycerin works perfectly well given orally. That was actually suggested years ago as a way of checking the shunt fraction. If patients got headaches after you gave them a pill of nitroglycerin, so you gave them a pill under their tongue and see if they got a headache, or measure in their digital fingers whether the vessels dilated. And then you gave it to them and told them to swallow it. And if they swallowed it and got the same response, you knew that most of their portal blood was being diverted around the liver. But it isn't reproducible enough to actually be useful in practice, but it was a great study to demonstrate that problem. So in summary, drugs, xenobiotics, and the liver intersect in many ways. Suspect there's a problem. Look up the data. There's just too many variables here. Can't memorize it all. Okay, so we'll take about a 10 or 12 minute break and then come back.